senior faculties, mentors, colleagues, and dear juniors. Today, I, Dr. Sejal Saklani, from second year PG resident from Department of Obstetrics and Gynecology, is going to present a case of a 34-year-old female with bad obstetric history under the guidance of Dr. Jaipur Chaudhary ma'am. Mrs. X, a 34-year-old Hindu female, homemaker, resident of Sikar, presented to antenatal OPD for routine checkup with amenorrhea of 6 months. Obstetric history, gravida 4, para 1, live 0, abortion 2. First spontaneous abortion at 2 months followed by dilatation and evacuation 8 years ago. Anti-D received to the patient. Second, full-term lower segment cesarean section. Female child 7 years ago. The pregnancy was uneventful. Patient received both antenatal and postnatal anti-D prophylaxis. Baby blood group was A positive. Baby died after 3 days of birth due to aspiration. Third, incomplete abortion at 2 months followed by dilatation and evacuation 1 year ago. There is no history of anti-D administration. Fourth is the present pregnancy, which is spontaneous conception. History of present pregnancy. First trimester, patient conceived spontaneously. USG fetal well-being was done at 7 weeks. Patient blood group was A negative. Husband's blood group was B positive. Indirect MGUMST test was done, which was positive. Further titers were done, which were 1:4. Rest all routine antenatal investigations were normal. RH antibody titers were advised monthly thereafter. Second and third trimester, patient was lost to follow-up and revisited the ANC OPD at 6 months. RH antibody titers were 1:32 now at 23 weeks when she visited us, which increased from 1:4. USG with middle cerebral artery peak systolic velocity Doppler was advised, which was normal. Patient followed up with USG fetal well-being with MCA-PSV Doppler weekly. Menstrual history. Last menstrual period of the patient was 24th of January 2024. According to that, expected date of delivery was 31st of October 2024 by Negley's formula. Period of gestation at the day when the patient revisited to the OPT again was 23 weeks 1 day. There was no significant past medical or surgical history. There was no significant family history. Patient was non-vegetarian by diet. Normal sleep and bowel habits. No history of drug allergy or any addiction. General physical examination. Patient was conscious, well oriented to time, place and person. Pulse was 80 per minute. BP was 122 by 70 mm of Fg taken in right arm in sitting position. Temperature was normal. Preconceptional BMI was 27 kg per meter square. There was no pallor, icterus, cyanosis or clubbing. Hair, skin, nails were normal. Bilateral breasts were soft. Normal changes of pregnancy were seen. No palpable mass, no lymphadenopathy and no pedal edema. Systemic examination was normal. Per abdominal examination, uterus was around 24 weeks. External ballotment was present. FHS was regular. Previous phalansteal scar was present, which was healed. Provisional diagnosis according to history and examination. A 33-year-old female, gravida 4, para 1, live 0, abortion 2, 23 weeks 1 day of gestation with RH isoimmunized pregnancy with previous 1 lower segment cesarean section. Further workup of the patient was done. CBC, urine routine and microscopy, viral markers, thyroid were in normal limits. RH antibody titer was 1:32 at 23 weeks plus 1 day of gestation, which was increased. USG fetal well-being and MCA Doppler were serially monitored and were normal, but at 33 plus 6 weeks, changes of hydrops were seen. The MCA-PSV was more than 1.5 multiples of meridian, mild ascites plus pericardial effusion was seen. We were in dilemma whether to deliver the patient or we should go for intrauterine transfusion. So we further consulted fetal medicine specialist. Further management will be told in the upcoming section. But before that, to give you all a brief review of RH isoimmunization in pregnancy, I would like to call upon Dr. Ankita Chaudhary, Senior Resident from Department of Obstetrics and Gynecology.
Good morning, everyone. I, Dr. Ankita Chaudhary, Senior Resident Department OBGY. I'm here today to give you all a brief overview of what is RH isoimmunization in pregnancy. Just to recapitulate, what is isoimmunization? Anyone? Isoimmunization refers to the formation of antibodies in an individual against the foreign antigen of another individual belonging to the same species. If we talk about the RH blood group system, which is also called CDE blood group system, it has around 50 antigens, but these 5 are the major ones. Coming to the order of immunogenicity of these RBC antigens, D being the most immunogenic, followed by Cal antigen, and so on. One important thing I want you all to note on this slide is that RH antigen is present on RBC as early as 38 days of post-fertilization, and only as little as 0.1 ml of fetal blood is sufficient to get the mother sensitized. Now, I would like to discuss very important aspect here, that is inheritance pattern of RH antigens. Basically, the gene for RH antigen is present on the short arm of chromosome 1. If it is present on both the arms, then the patient is homozygous. If it is present on one arm, then the person is heterozygous. Now, what is the need to know the zygosity of the partner? Why we want to know it? This is because if a homozygous RH positive father mates a RH negative mother, 100% offspring will be RH positive. But if a heterozygous RH positive father mates a RH negative mother, there is a chance that 50% offspring can be RH negative also. This slide actually shows us the incidence of RH negative blood group of India. This map shows us the distribution of RH blood group. This is the data taken from the 2020 systematic review. The highest is in the northern region, that is 7.12%, and lowest is in the eastern region. And on average, Indians are 5 to 7% RH negative. Coming to the important thing, pathophysiology of isoimmunization. When the mother first gets exposed to the D antigen for the first time, her immunocompetent cells get activated, leading to the formation of antibodies. But in the first sensitizing pregnancy, the antibodies formed will be IgM type. These are heavy in molecular weight and can't cross the placenta. So usually the first pregnancy remains unaffected. But as in our cases we have discussed earlier, the patient had a history of abortion 1 year back, which was not followed by anti-D. So it might have become a sensitizing event for her, and when she again conceived and exposed to the D antigen again for the second time, due to the amnestic response, this time the antibodies formed will be IgG type, and they will be formed huge in numbers. They can easily cross the placenta and cause the hemolysis of the fetal RBCs, leading to the hemolytic disease of newborn and fetus. Now, what is actually the aim of antenatal management? It actually depends on the maternal immune status. If the patient is not still sensitized, so we have a scope of prevention of isoimmunization. But what if the mother is already sensitized? Then there is no role of prevention, and we have to go for detection of fetal anemia and timely diagnosis. Sensitization is determined by the test called indirect Coombs test, which is also called antibody screening. This is the algorithm which actually shows how we can prevent isoimmunization in an RH negative unsensitized female. When an RH negative mother comes to us in the OPD, the first test we go for is the blood grouping of the partner or the father. If the partner is RH negative, then no further follow-up is required. But if the partner is RH positive, then we have to go for the next test, that is indirect Coombs test, to know if the mother is still unsensitized or not. If the test is negative, we have to repeat this test at 28 weeks. And if the mother is still not sensitized, then we can give anti-D at 28 weeks. Now you all must be wondering why we chose this 28 weeks. Because the chances of feto-maternal hemorrhage before 28 weeks is less than 0.1%. And the dose which we are giving at 28 weeks, this will provide protection for the next 12 weeks, and we can deliver the patient at 38 to 40 weeks. Followed which we have to give the postpartum prophylaxis if the baby is RH positive. This is the algorithm when the ICT is negative and the patient is not still sensitized. But what if the patient is already sensitized? Then we have to go for the antibody titers. As in our case, she was having an antibody titer of 1:4 in first trimester, which rised up to 1:32 at 6 weeks. So there is a chance that the fetus might develop anemia. So now we have to monitor the fetus with a very good non-invasive tool we have with us, that is ultrasound Doppler for middle cerebral artery peak systolic velocity index. I would like to ask, any one of you can tell me why we chose MCA-PSV Doppler? Yes, please. Okay, thank you. Yes, she is right. It is because fetal anemia is a high cardiac output state, so the hydrostatic pressure is increased, and it is also a low viscosity state. So the best results has been seen in the middle cerebral artery, so we take it. Now this middle cerebral artery peak systolic velocity, it varies with the gestational age. If its value is less than 1.5 multiples of the median for that gestational age, then we can monitor with it 1 to 2 weekly, as the risk of developing anemia is less, and safely deliver the baby at 37 to 38 plus 6 weeks. But if its value is more than 1.5 moms, or we can see the features of high drops on the ultrasound, then the management depends on the gestational age. If the age is more than or equal to 34 weeks, the fetal has gained its maturity, we can deliver the baby after the steroid coverage. But if it is less than 34 weeks, then we have to go for fetal blood sampling, followed by intrauterine transfusions, which will be discussed in detail by Dr. Rekha. So now I'd like to call Dr. Rekha, fetal medicine expert, to tell her the further proceedings. Thank you.
Good morning, all respected teachers and dear colleagues. So today's discussion was a case of Gravida 4 Para 1, no live issue, and now we were following this lady from 31 weeks 1 day gestation age, and we want a safe and healthy baby. We want to give her safe and healthy baby. So here she was RS sensitized, so there was risk of fetal anemia. So there was risk of fetal anemia. So non-invasively we monitor fetal anemia by middle cerebral artery peak systolic velocity. As the resident told that it is a high output state of fetal anemia, so blood is transferred to vital organs, and in vital organs this middle cerebral artery just reflect that high throughput condition, and in this middle cerebral artery we take the Doppler just when it arrives at the origin of carotid siphon, and we just take in the beam of ultrasound beam, we put the cursor, and then we check the peak systolic velocity in this middle cerebral artery, and then as per gestation we have charts that which peak systolic velocity correspond to anemia and which is for normal for health. So if peak systolic velocity is normal for gestation age, it means fetal has not developed anemia till now, and if peak systolic velocity is high and more than 1.5 multiple of median for that gestation age, it means fetus has developed anemia, and we need to do either delivery if gestation is more than 34 weeks, or either we need to transfuse the fetus in utero if fetus is less than 34 weeks. So this monitoring we can do from 16 week onward in the fetus for fetal anemia. Sensitivity of this technique is around 85%. And after 35 weeks, sensitivity decreases itself. MCA-PSV falsely may be high, so it is around 70%. So along with middle cerebral artery, we check the fetus sonographically also, and we have few signs of early high drops or late high drops in the fetus, like when the fetus develops anemia, then at the end stage fetus goes into hydropic changes. Hydropic changes, it means fetus develops fluid into the cavities like ascites, pleural effusion, pericardial effusion. So along with this monitoring, we also check the fetus for these signs, like we check for either whether fetus had developed pericardial effusion, pleural effusion, and MCA-PSV is also. So we take together both of the signs, sonographic signing and middle cerebral artery peak systolic velocity. So in our patient, we were monitoring this patient from 31 weeks to 1 week onward, and these middle cerebral artery peak systolic velocity was fluctuating between 1.29 to 1.5 multiple of median. It means it was showing that fetus is having mild anemia, just have sensitized but still not severe anemia, because we do transfusion after 1.5 moms when fetus has developed severe anemia, because each intervention has its risk of loss of fetus, so we do intervention at its proper indication. So we were waiting whether fetus develops anemia or MCA-PSV is more than 1.5 moms, but it was just between 1.29 to 1.5 moms. So we were following the patient from 31 week onward weekly, but when the patient reached 34 week, then we decided that now we will go for delivery because it is just fluctuating. But in last visit when we saw the patient in sonographically, then still these are the MCA PSV which we were getting, that it was just 60 and 67, and you will see in the chart that 62 and 73 are just 1.5 mom for the 34 week. So still by sonography and non-invasive monitoring we were not convinced that baby is having severe anemia. So as per MCA PSV it should be delivered. But when we looked into the USG, then we find that there was little bit streak in the abdomen of fluid and little bit streak in pericardium also. So we were doubting that whether his fetal is developing severe anemia or hydrops, but we were not sure because these may be a normal finding also, just streak. So out of this we just decided that we will do a codosynthesis, just blood sampling of the fetus, and if in blood sample fetus had severe anemia less than 7 gram, then we will give transfusion, and if baby is more than 8 gram or 9 gram, then we will deliver because gestation was 34, baby was mature. So we just planned a codosynthesis, and in codosynthesis we take the blood from umbilical vein of hepatic portion. In liver, this is the umbilical vein which enters and forms the portal system of the fetus. So we take the blood from this side, and when we take the blood and we sent it for the testing, then we found that hemoglobin was 5 gram %. It was severe anemia and blood group of baby was O positive. So it was severe anemia, and our NICU colleague know that if we deliver a severe anemic fetus, then NICU mortality is around 25 to 30%. It's high mortality to deliver a baby of severe anemia. So we decided that we will do the blood transfusion first to the baby. We will make the baby healthy, then we will deliver the baby. So we planned for intrauterine transfusion to the fetus. So in intrauterine transfusion, we have few prerequisites because fetus is inside womb. If there is any reaction or wrong volume we give, then we can't save the baby. So we need to be very precautious for this. So we have few prerequisites for the blood. What kind of blood we need for the fetus? So this blood should be O negative, so that mother's antibody cannot break it. So we take the O negative blood for the fetus. This blood should be freshly donated within 24 to 74 hours, and it should be antibody screened, cross-matched with mother, so that it should not be react to mother, and it should be all screening, HIV, HBS, HCV, syphilis, all should be screened in this blood, and hematocrit of this blood should be high, around 70 to 85% hematocrit should be there. It should be leukodepleted, and it should be gamma irradiate, so that graft versus host disease should not be there. So this blood is prepared by blood bank. We have a lot of support of blood bank for this kind of blood bank. So I will call Dr. Somya for the brief about the blood bank, how they give this kind of blood bank to us. Dr. Somya.
Good morning, respected faculty members. Myself, Dr. Somya Sharma, JR1, Department of IHBT, and I will be speaking on the preparation of the IUT bag. So once the decision for intrauterine transfusion is taken, then a O negative leukodepleted packed red blood cell within 72 hours of collection needs to be arranged. This is a picture of leukodepleted filter bags that we are using at our center. The collected blood then is tested for the blood grouping, cross-matching with the mother sample, screening for the unexpected antibodies, and screen for the transfusion-transmitted infections. Then the blood is centrifuged at a high RPM for about 3200 to 3600 RPM for about 10 minutes, such that the hematocrit is more than 70 to 85%. This is a picture of fully automated centrifugation machine that we are using at our center. This is a picture of the product, O negative leukodepleted PRBC, and this is the irradiation slip that we are using. So after irradiation, the red knot is replaced by a black dot. That means the product is irradiated and now ready to be issued to the patient for transfusion. So I'd like to call Dr. Rekha ma'am again to take this case.
So this was about the blood bag which we get from the blood bank. Now we need to calculate the blood volume also, what we are giving to the fetus, because it is no double exchange. We are not extracting out from the fetus, we are just giving to the fetus, so it should be very precise. So we have many formula, one formula which by which we calculate the fetal blood. In this we have fetoplacental volume, and in fetoplacental volume formula we have ultrasound calculated estimated fetal weight, and it should be in grams. So by this we get a fixed entity of fetoplacental volume, and then we have need to calculate this with the hematocrit. One is the target hematocrit. What hematocrit we want in the fetus after transfusion. Like our fetus was just 5 gram, and hematocrit was around 15. So we will not go more than 3 times of this hematocrit. So not more than 45 hematocrit should be target, but we kept our target low. We kept our target around 35, just so that a hydropic fetus can tolerate the blood. So that we just kept our target hematocrit was 35, and SCT of first sample. When we prick the fetus for blood transfusion, then we take out some sample, first sample of the fetus, and we send it just immediately to the center, and we get the hematocrit done. This is the hematocrit of first sample. Then we put it into the formula, and we just calculate the blood volume. And third is HCT of donor blood. Like we have said that we need the hematocrit of blood bag between 70 to 85%. So this we put here. So these hematocrits are taken into together in fetoplacental volume. By this we calculate the volume what we have to give to the fetus, and we have in our SFM Society of Fetal Medicine paper, we have a chart. In this they have calculated fetal volume as per gestation age and as per fetal weight. And in this is given that what hematocrit you want to raise. Like my fetus had 15 hematocrit, I want to raise 35 hematocrit. So 20% hematocrit I want to raise. So I will transfuse the blood which is below the 25% hematocrit. So my fetus was 33 to 34 gestation age. So I will give blood between 83 to 92 ml volume I will give. So we can use in ready-made tables also, but better to put in formula. So this was the just preparation before transfusing the blood. Now how we transfuse the blood to the fetus. So we do this procedure in our routine sonography room, but we maintain the asepsis. Just before the procedure we do asepsis of the room, we clean the machine and the surrounding area, and then we paint and drape the mother. Then we put our sonography machine, and then we put the sonography guided needle into the fetus. So before starting transfusion, we need to just paralyze the fetus, because fetus is live, moving. So when we are giving transfusion, baby should be still, so that we give a muscle relaxant. We call it atracurium, and atracurium dose is 0.4 mg per kg. We calculate it, and we give this atracurium into the thigh muscle of the fetus, guided by ultrasonography by the probe, and we give in thigh atracurium. Then baby get relaxed. Then we start our transfusion. So then we put the 20 gauze needle into the intrahepatic portion of umbilical vein, and then we start transfusing. First we take the first sample for the first hematocrit. Then we start transfusion. Then during transfusion we just keep an eye on that our blood transfusion, that blood is going to the fetus. This is not starting. Yes. So during transfusion, just we put a needle, like you are seeing this is our 20 gauge needle. We put this needle into this left portal vein. This is the just continuation of umbilical vein. Background no. Sound, I don't know. So just just we put the needle into the hepatic portion of the umbilical vein, and then we start transfusing, and we give around 85 ml pre-calculated volume to the fetus. And during that transfusion, we keep monitoring of the fetal heart and this needle, and the blood volume is going properly. Like you will see that the beam is going, and this is the continuous blood is going. So we give 85 ml of volume, and then after this volume, when we have transfused this volume to fetus, then we extract the second we take the sample of the fetus after transfusion, and then this second blood sample also sent with for the testing, and this is the post transfusion hematocrit and hemoglobin of the fetus. Like in this fetus, post transfusion hematocrit was 34% and hemoglobin was 12 gram%, and middle cerebral peak systolic velocity also decreased to 40. So both of the things we check after transfusion. Then we keep the fetus mother on fetal count monitoring, and then we keep the patient in follow up with obstetrician again. So in this patient, then after first transfusion, we keep the patient in follow up for 1 week. Then after 1 week, we again repeated the sonography. This was around 35 weeks she at that time, and in USG again middle cerebral artery peak systolic was again more than 1.5 multiple of median, because when we blood give, then breakage of blood is still hemolysis is ongoing into the fetus, and it around breaks 2% hematocrit per day. So we gave the hematocrit of around 34%. So in 7 days, around 10 to 14% hematocrit. Again hemolysis is there. So again it is around 16 to 20 hematocrit was there. So we planned one more IUT, and we did second IUT. After second IUT, hemoglobin was 13 gram% and hematocrit was 38%. Now we planned for delivery because patient was just 35 weeks, and now we have secondly raised the hemoglobin. Fetus was normal moving, and so we refer back to the obstetric department for further management and delivery.
Thank you, madam, for the introduction. So myself, I'm Dr. Siva Kumar. I'm first year DM resident from Department of Neonatology, and I've been assigned to do the CCR under the guidance of Dr. Saurabh Singh. So we were handed over the baby. It was a late preterm male baby, appropriate for gestational age, and the birth weight was 2.71 kilos. And on general examination, the baby had no obvious congenital anomalies, and there were no features suggestive of hydrops. And the main problem that we were expecting to deal with in this baby is neonatal hyperbilirubinemia that could lead to kernicterus in the long term if not addressed adequately in time. So the options for the problem are phototherapy and IV immunoglobulin and exchange transfusion, out of which we had given phototherapy and exchange transfusion. IV immunoglobulin is not routinely indicated, so we had started with phototherapy and we had moved on to exchange transfusion, and the reason for escalation will be discussed henceforth. So the baby also had mild respiratory distress syndrome, for which we had started the baby on high flow nasal cannula with 21% FiO2 and a flow of 5 liters per minute. And nutrition and adequate hydration is paramount in neonatal hyperbilirubinemia, so we had started the baby on nasogastric tube feeding. For the problem at hand, we had started the baby with intensive phototherapy. That is, we add 2 phototherapy units, and we try to minimize the distance between the units to as little as possible. And we had sent the cord blood samples, and we had intimated the blood bank that we may have to perform exchange transfusion for the baby. And for the same, we had secured umbilical lines. And once we got note that the cord bilirubin was 8 milligram per deciliter, and the cutoff for exchange transfusion is more than 6 milligram per deciliter in cord blood, we had moved ahead with a plan for a double volume exchange transfusion. So the double volume exchange transfusion is the modality that this is the most effective modality that we have that can deal with neonatal hyperbilirubinemia, and it mainly acts via it corrects any anemia if present, and it removes the antibodies that are coated with the RBCs that are coated with the maternal antibodies, and this process ensures that almost 85 to 90% of the RBC coated antibodies are removed. The blood volume is, as seen in the name, it is a double volume exchange, so that is about 170 to 200 ml per kg of the neonate's blood. So 60 to 80 ml per kg is what a baby has in its intravascular space. So we are performing a double volume exchange, and the blood product that we use, in the a total volume of blood, we have to go for the 2/3 of the blood has to be PRBC, and the remaining 1/3 has to be plasma, preferably less than 72 hours in case of PRBC. So these are the two photos that show the procedure in a simplified manner. We secure the umbilical lines over here, as you have seen, and for the procedure itself, we have to make sure that we have two 3-way stopcocks in series, and as you can see, the procedure involves we will be drawing blood out of the baby and we'll be sending in fresh blood. So as you can see, the first line over here, this is the proximal, this is the umbilical line, and this tubing over here, this is this goes towards the waist. That is the blood that we draw from the baby, and this tubing over here, this is connected to the fresh blood bag that we order from the blood bank, and the distal syringe that is connected over here, this is used to pull the blood and to discard it, and then we'll be drawing the blood from over here by ensuring that the stopcocks are arranged appropriately, and the blood will be injected into this. So we perform a double volume exchange in aliquots of 5 to 10 ml per kg, and usually the procedure is finished in about 1.5 to 2 hours. And so after double volume exchange, we had arrested the rise of bilirubin to about 7.6 milligram per deciliter. So as you can see, you see two nomograms over here. The first one is the exchange transfusion nomogram, and the second one is the phototherapy threshold. So as you can see, the serum bilirubin after exchange transfusion was 7.6 milligram per deciliter. So that would mean that a baby fits the criteria to be continued with phototherapy, as you can see that at approximately 8 hours of life, the exchange threshold is very much above 7.6, almost at 14. So phototherapy was continued for the baby. There was no hypocalcemia. Hypocalcemia is a known complication in a double volume exchange transfusion due to the citrate in the blood chelating the calcium, and a baby was continued on a nasogastric feeding, and we had increased the feeds as per the baby's tolerance by day of age. So after double volume exchange, we tend to repeat serum bilirubin at 6 hourly, and once the bilirubin drops down to a level where exchange is not indicated, we repeat our serum bilirubin every day, once every day. So the further serum bilirubin levels show that there was no need for a second exchange transfusion. And as far as feeding, we had established the baby on pallidi feeding. As you can see, this is a small spoon over here. This is his pallidi is what we use to bridge the gap between nasogastric feeding and direct breastfeeds. And direct breastfeeds were started for the baby on day of life 6. And before discharge, we had done a brainstem evoked response audiometry, because neonatal hyperbilirubinemia, if not managed adequately, this can lead to kernicterus, and BERA is done so as to see if there's been any damage to the 8th cranial nerve and the auditory system, which was normal. So baby was discharged on day of life 12, and we had established breastfeeding adequately with the mother, and we had found no evidence of any neurological anomalies. And as mentioned earlier, the BERA done was normal. So I hereby invite Dr. Ankita Madam to continue the.
Thank you, Dr. Siva. Before summing up this session, I would like to say a few words about the prevention of isoimmunization in pregnancy. At present, in current scenario, we have only one available prophylaxis, that is NTD. There are some guidelines according to different organizations of Obst Gyne, which says blood typing of the father and the mother should be done at the very first visit with RBC antibody screening. This RAADP, that is routine antenatal anti-D prophylaxis, is to be given to all Rh negative unsensitized women at 28 weeks, and a postpartum prophylaxis to be given within 72 hours if the baby is Rh positive. The dose is 300 micrograms, which is given intramuscular, preferably in the deltoid region. One important thing to emphasize is that NTD has to be administered after every suspected sensitizing event, which is regardless of RAADP. Now you all must be wondering how effective is this drug, since we are talking about it again and again. You can see from this data, the risk of alloimmunization is 15% if the patient has not received this neither antenatally nor postpartum prophylaxis, which reduces to 1 to 2% if the patient has taken postpartum prophylaxis, which further drops down to 0.1% if both the prophylaxis has been taken by the patient. So you can see this drug has done wonders. At last, to conclude, I would like to tell you why we actually picked up this case. To highlight the importance of NTD prophylaxis in today's scenario, the significance of regular antenatal visits and follow-up, to show you how a single case of abortion can become a sensitizing event when not followed with the NTD dose. When this patient came to us, she was very anxious because of her bad obstetric history, but because of a good infrastructure and multidisciplinary approach we have in this hospital, we managed to deliver a healthy baby to her. And this is a pic of her with her baby. Thank you all. I would like to extend my sincere thanks to the management team of Mahatma Gandhi Medical College and Hospital, CCR Review Committee, Department of Fetal Medicine, Hematology, Neonatology, and especially to our patient for giving this opportunity to learn and to grow. Thank you all of you.